but no worries. So feel fortunate to be, where I'm at, and I'm happy to be here with you all today to talk about myeloma and try to answer any questions that you might have. So, I think may just be best if anyone has any questions to open up with. I don't know that I have a specific set agenda of things to talk about, but I think we can hopefully cover a bunch of different important topics to y'all and talk a bit about those. So I don't know if anyone has any questions to start with that they wanted to discuss.
I do.
Yeah.
I just got an email yesterday from U of M inviting me to a breakfast, I think, to discuss liquid biopsy to determine cancer. And I wondered where that stands relative to determining multiple myeloma and whether it could be used to replace bone marrow biopsy to determine MRD.
Yeah, it's a great question. So I've heard some about efforts to develop liquid biopsy tests, which can allow for early detection of cancer. And in general, the way that these tests work are to collect blood, send the blood off to a lab where they'll do gene sequencing. And then what they can do is find and sequence lots of different fragments of DNA that are in the blood, and have a way of downloading, analyzing all that data, putting it together to try to find, what's the person's own genetic signature, and then are there potential mutations in genes that we know are related to cancers. So there are certain genes that, for example, in melanoma, skin cancer, where there's specific mutations that can be found that are unique to that. There's a lot of efforts to try to, use these blood tests as screening for multiple types of malignancies. And I think it's an area that it's potentially exciting. I mean, I think if for many types of diseases, we could detect them earlier, there's the possibility that those could be prevented from developing into, active cancers that have spread beyond the tissue that they're originated in. In the area of myeloma, so I'm not specifically aware of those tests having specific applicability to myeloma, particularly at U of M. I think it's just looking at, in general, pan cancer. They're just doing sequencing of everything, trying to identify mutations, and there's nothing, I think, specific towards myeloma. But I think that, we're going to capture, I think if they're going to start doing these types of tests, the precursor conditions to myeloma are relatively common in the general population. If you think about people over the age of 50, if we do a protein electrophoresis, we're going to find an M protein or evidence of a monoclonal gammopathy, and estimates around 3 to 5% of the population over 50, and that number just goes up by age. So if this sort of testing is going to be rolled out to be screening for cancer in a large group of people, there's going to be some of those patients that have monoclonal gammopathies. I think that I don't know. I think the unique aspect of myeloma and plasma cell disorders is the protein electrophoresis test can find a monoclonal protein that precedes the onset of the disease, in many cases by decades, years, decades. So there is, without having to do gene sequencing to find evidence of the tumor, we already have a test that can develop, that is active, where we can find evidence of early myeloma. What's missing is the screening for these conditions is not as established as it is for other types of tumors, like colon cancer, where everyone gets a colonoscopy at age 45 or 50, or mammograms are done for early detection of breast cancer. There's no screening program for monoclonal gammopathies that exists right now. And I think that partly that's because there's not, I think, been enough data to show that that is a worthwhile thing to do, that if we detect it early, that there could be some sort of early intervention. There are a few very exciting large-scale studies that are in progress right now looking at screening for monoclonal gammopathies. Some of you may have heard of them. ISAP trial, which is in Iceland. It's this amazing trial where they managed to enroll like half the population of their country in like 6 months. I think they're like 80,000 people, and screen them for MGUS by sending protein electrophoresis and free light chains, and then trying to assign those patients in whom they did find MGUS to either no more testing or the usual route of testing, which would be to check the blood test once a year versus a more intensive schedule. And they, every year at the large hematology conferences, there's multiple presentations that are coming out of this. Most recently, practically speaking, they have allowed us, they developed a model where we can try to help us predict who we might be able to do an initial bone marrow in to determine if they have smoldering myeloma or MGUS, and they give us a % chance of them having 10% plasma cells or more. I think there's a lot to potentially come from that study that could, I think we're going to learn from that about whether or not there's value in screening the general population for MGUS. Additionally, there's a PROMISE study, which is being led out of Dana-Farber in Boston, where patients can sign up online, or first degree family members or people of African American heritage or African heritage of a certain age can sign up online to have, and without knowing if they have MGUS, send blood off to be screened for this. So those are efforts that might show us the value of screening tests for early detection of plasma cell disorders, but currently we don't have like a national program or recommendations for any sort of regular screening. To get back to the question at hand about trying to non-invasively assess for these for the status of people's myeloma, MRD, there's been some efforts to try in the past to do blood testing to see if you could do MRD testing in the peripheral blood to try to determine if that could replace the bone marrow-based MRD tests. And my understanding is that those haven't matched up well enough to show the same results enough for you to say you could skip the bone marrow and just do the peripheral blood-based MRD test. There's some other technology that is being developed that can analyze the type of proteins that are in the blood by size. It's called mass spectrometry. And there's some centers, Mayo, Sloan Kettering, I think University of Miami they're developing tools to try to do mass spec for potentially analyzing MRD to find tiny amounts of these monoclonal proteins that we wouldn't otherwise be able to detect with our usual tests. And I think there's studies that are ongoing to see if that might be a method to non-invasively assess for MRD. I think that it's possible that could develop into a tool that we use regularly, but I think those results are still, it's too early, I think, in analyzing whether or not those could be used to kind of replace the bone marrow. I think it'd be great to replace the bone marrow if we could.
Are there drug trials on that you know of?
I think that is likely integrated into clinical trials. I don't know. We don't have that particular endpoint added to any of our clinical trials that we're having at U of M right now. And I am sure it's included in some clinical trials that are in progress. But I don't have any more info about like when. I think when we'll know more, but I think we're going to hear something at some point, and I don't have an eye into the status of that particular research question. But it's a great question.
I'm always interested in patients, and I'm wondering if you see patients who come to you more knowledgeable, or they come with symptoms sooner. Do you find that the patients are different in the 5 years you've been here?
I think that there's a lot of information available for myeloma, and certainly a number of organizations have grown to help empower myeloma patients to know more about their disease and to engage with new developments. Some of those include myeloma crowd, which I think is now called Health Tree, I think has been a great network where they host a bunch of educational videos, and there's I think a lot that patients can find on there. The Multiple Myeloma Research Foundation also has a number of educational items that I think are helpful in having patients know more about their disease, and meeting patients for the first time and they're asking about lots of myeloma topics that suggest they've learned a lot just from initial reading from what they can find online. So I do notice that many of the patients that I meet already know a lot about their disease, but there's a wide spectrum. I mean, I think there's many people who I meet who have myeloma who've like never heard of it until they got the diagnosis, and I think there's a huge learning curve for this complex disease, and all the treatments and the testing and the side effects and the vocabulary for understanding all is huge, especially at the start, just learning what's important and what to follow and what to pay attention to. So over the 5 years, I mean, there's been so many differences in the 5 years that I do notice many of my patients know a lot about the disease. It's hard to say that's been more present over the last 5 years, just with all the other changes that have been going on in the world. But I think that the patient education networks have developed a lot, and I think to everybody's benefit. And if anybody hasn't heard of those, I encourage you to go, look those up online. They have even resources for one-on-one coaching I learned about recently from Health Tree. I got an email this week about that. So I think if you have any questions, they have the ability to reach out one-to-one and connect you with understanding who is the potential myeloma expert in the region. What can you think about with clinical trials, education, coaching. Like they have a lot of these groups have lots of different resources that I think are really helpful if people engage with them. Thank you for the question.
Just speak up if you have a question there's a question down.
Dr. Pianko, what is the current status for people with COVID? John has COVID. He went with a bad problem and he went in and they said he was COVID positive, didn't have symptoms. So he was supposed to have a treatment yesterday and a dental appointment, everything. So what's happening from now on?
It's a good question. I know that the world is I think changing in terms of lots of precautions, but there's still COVID out there and people are still getting COVID. And I think that what I've seen lately is I haven't I think remarkably in the vaccine era, I haven't had patients with myeloma being admitted as sick as they were in the pre-vaccine era just from COVID. Oftentimes they end up in the hospital for a problem, and then they also have COVID as well, which is most of the time the case.
Yeah.
So I think that whenever someone who has myeloma, either active or potentially in remission, I think they should be considered, immunocompromised. And I think that some people are more immunocompromised than others. It's not a great measure to say who's more immunocompromised than another patient, not any sort of one test, but I think that where possible, some of the antivirals that have been developed for COVID, I think are still worth trying to use to try to keep the disease mild.
Severe.
So I think that if someone's in the inpatient world, that remdesivir drug is useful. In the outpatient world, the Paxlovid drug from Pfizer, I think is our general recommendation. So I think if someone develops symptoms, I think that's still going to get a test is useful to understand if you might have COVID in the outpatient world, and engaging with your care providers to see if they could prescribe Paxlovid to try to help keep it mild. So I think that with regard to vaccinations, after doing the primary series, at least the latest status that I've heard, it really is that they came out with this bivalent booster last year that came out in about September. And I've not heard of any updates for the coming year, kind of like they do with flu vaccines, where they'll make a prediction of what flu strains are circulating, create a cocktail vaccine that includes their best prediction of which 3 variants or 4 variants are going to be circulating in the flu world. I haven't heard of that for COVID. I mean, a while back, I heard rumors that they would be doing annual COVID vaccinations, but I haven't really heard any updates from that. So I don't know the status of whether or not vaccines are going to be continue to be updated. If there's going to be specific recommendations for boosters. I would encourage patients to get the primary series and just to get all the vaccines. And because I palpably speaking, I've noticed a difference where I had patients who were very sick early in COVID, who just had COVID, had, really, I had myeloma under control, had no other, real issues, and ended up very sick from COVID. I do think the vaccines have been useful, and, there's been some more limited effects of COVID vaccines in myeloma patients, but I think many myeloma patients have been responding to the vaccines well.
And my
So-
concern continuing his myeloma treatment. They just started 3 of the new treatment for him.
Yeah.
What do we do? How long will we wait? What will happen?
Well, with that specific situation, I think we often try to if someone's sick from COVID, give them a little bit of time to recover from that. So certainly, I'd love to communicate with the specifics about that case, maybe at a little bit later, and we can talk about the details.
Individual.
I think it's always individual. You have to look at the situation in
Thank you.
particular, but yeah, hopefully he feels better soon. Yeah. Thank you.
Thanks.
Are they recommending a second bivalent shot?
I haven't heard of that yet.
Well, there was something on the evening news
Yeah, I
about
agree.
making sure you got it. Now, maybe that's for people that never got the shot. I don't
It was
know.
unclear.
Yeah,
Yeah, I think it's been a problem that the recommendations have been unclear. I haven't heard any specific updates beyond completing this single. So the initial series of 3 or 4 vaccinations. I think that probably the CDC page for immunocompromised individuals, what I usually reference when I get this question. If I'm in a clinic, I usually always pull up the page because I feel like many times the page changes in between the last time I looked and the next time I looked. So, but I haven't heard of a recommendation to do a booster with the bivalent vaccinations. But I think it's worth looking again. It's been a little while since I've thought specifically about that question. So I think it's worth looking again.
What is the bivalent booster? Is that flu and COVID together? Or no?
2 strains of
Two strains of COVID.
2 strains of COVID, or proteins from 2 different strains from COVID. Yeah, from the original strain that they made the vaccine from early on. And then I believe they took the Omicron variant and then did sequencing of the protein and then just created added the mRNA for that protein to try to cover more like current strains.
The news just said they weren't even giving the original shots anymore, if they're correct. They were just doing the newer ones, and I don't know if there's a newer one they didn't indicate it was a brand new one in addition or just a booster. I don't know.
Yeah, I think that the situation, there's lots of people that have had different levels of vaccination. I guess they had some of the single vaccinations and never got the bivalent, or maybe never got vaccinated and are starting with the bivalent. I think it would make sense, and I'm not sure what exactly the recommendations are, so I'm gonna have to sort of look at the up-to-date CDC recommendations we could. But I think that it would make sense, I think, to do bivalent to start with, because I think that those are sort of the more contemporary strains of COVID that are around. Yeah, so in general, I mean, I think COVID continues to be a concern. It certainly has been still around in patients, but patients are certainly, I think, less sick from COVID than in the past. I think that one of the next important topics, I think, just relates to the degree of immune compromise. And so there's been some new drug development.
As of April 19th, they just said that they changed it.
That's Evusheld, actually.
Oh,
So Evusheld was that preventative antibody that they were giving. So the new strains mutated such that it didn't even help protect people from them. So I think that yeah, I think it's probably further down.
I pushed on the, I pushed on
But I
the,
think if you click maybe click the link from my academic.
okay. It might be on the, I pushed the immune, no compromise button.
Yeah. So, I mean, I think navigating around this website and speaking with your care provider about your specific situation, I think would probably be the most, helpful. I think there's probably the individual recommendation. I think there's a lot of places to navigate on the site, so I don't want to get necessarily, I think, bogged down in navigating through this
What
at
is
the
the
moment,
name of
but
the website?
what's that?
What is the
It's
name of
the
the website?
CDC coronavirus vaccine recommendation.
Yeah,
think
all I
would be
did
the-
was Google's CDC recommendations for COVID, and it popped right up, first thing. We got it.
What is the best way to measure your immune system ability? What degree of immune compromise do you have?
It's a great question. I think there's not one way to do it. I think one can think about the status of one's disease. So people who are newly diagnosed, or those who are undergoing an active relapse where maybe their blood counts are low. I feel like that type of disease status would make me feel like someone might be more immune compromised than someone who's perhaps in remission on maintenance lenalidomide, feeling well. There's some lab tests that we can look at that can help guide our estimates of what the immune function might be.
Like ANC?
ANC,
Absolutely.
neutrophil count is a marker for really helping protect us from our bacterial infections, and even our own bacteria in our guts that could end up in the bloodstream is oftentimes what happens. And when people get neutropenia or low neutrophils and get a fever from that, absolute neutrophil count, absolute lymphocyte count is another marker. Lymphocytes are cells that are immune cells that both fight cancer and infections. They can fight viral infections and directly can fight myeloma as well. One of the side effects of some of our treatments is that sometimes these, both the absolute neutrophil count and the absolute lymphocyte count can be diminished by myeloma treatment or myeloma activity. It's hard to, I think, draw direct conclusions as much about the absolute lymphocyte count as it is the absolute neutrophil count, where we might say, if you have a low neutrophil count, you get a fever, you should contact your doctor and probably come to an emergency room to make sure you don't have an infection. We think about, there's two arms of the immune system. There's the cellular immunity. And so that's what those two measurements assess: the absolute neutrophil count, the absolute lymphocyte count. Those are kind of rough measurements of how many of those individual types of cells are present. And then there's also the humoral immune system. So this is like the immunoglobulins. So myeloma is a disease of cells that make our immunoglobulins. Often results in because of the treatments or because of the disease, patients have low immunoglobulins. The immunoglobulins are antibodies that we have protect us from getting infections, like upper respiratory infections in particular. And so we deal with this unfortunate consequence that we treat myeloma, we have to kill cells that make antibodies, and we kill, in many cases, both the plasma cells that cause myeloma as well as the normal plasma cells that may be present. We do see that patients, after they do a treatment like a transplant, or maybe they stop their multi-drug treatments after their initial therapy, that some of the immune system does recover over time. So I think that there's a relative difference. You think about all these factors: the treatment, the disease, the lab tests. You kind of put that all together to get a gestalt about how immune compromised someone is. And I think the other piece of it is really events. So if you can have two individuals who have the same labs, the same story, and one person's had several recurrent infections, then clearly that person is probably more immune compromised than the person who hasn't had any infections at all. And there may not be a test to help us with that, but that's just the history, right? So I think where I'd like to, maybe pivot that question is, we have some new drugs that have come out in myeloma recently, particularly, or one new drug, this bispecific antibody called teclistamab, which is a drug that helps redirect the T cells in the immune system to bind to, so it's a bispecific antibody. So one side sticks to the myeloma cells, the other side sticks to the T cells, and it brings them close together. And it makes the T cells, which are also lymphocytes, fight the myeloma cells. This can lead to this type of side effect called cytokine release syndrome, where you need to start the drug in the hospital and then transition them to the outpatient setting after that risk has cleared. I think one of the concerns with these agents, they seem to be highly effective in people who have had a lot of myeloma treatment. So it's a wonderful, I think, new tool to have. I think the other side of the coin is that these drugs are quite immune suppressive, and that we're seeing significant infections in patients who are getting these drugs. So it warrants, I think, having a close watch on how patients are doing. And, I think if there are questions of infection, that we need to kind of look into those. Particularly, sometimes there are, I've had patients get COVID. In some of the early trials with that drug, there were severe COVID infections on the study where that drug was being developed. Some of that happened before the vaccine era was really in play. So I think that some of the effects of that drug makes the immunoglobulins quite low, the IgGs quite low, by its effect of killing the normal plasma cells and the myeloma plasma cells. And through participation in studies where we look at this drug or drugs like this, there can be consideration for giving immune globulin replacement, or IVIG, as a way to supplement people's antibodies that they can't make on their own anymore, because the drug is really knocking out the source of it. And that has some use, I think, in helping reduce the impact of infections, at least to some degree. We try to prevent other infections, as we do with other myeloma drugs like acyclovir we use to prevent shingles. Pneumocystis is an atypical fungus that sometimes people can get if they have very low T cells. So there's some preventative antibiotics that can be used to prevent that. But I think we have to have a high degree of caution. It's early in the days of using these drugs, and I think we need to be cautious about infections popping up as a problem. They're very active, even if people have used up really all the other active myeloma treatments, but the risk of infection is absolutely real, and we need to be very careful about that. And I think it's, we also, some of the early trials that have been used, really what we do right now is do continuous use of these drugs. I think as we learn more about how the best schedules for them, maybe it'd be better to give this drug for a 6-month period of time and then stop and let the immune system recover a bit, and maybe give another pulse of drugs. So these are kind of, study questions that aren't really actively, being looked at now, because we don't know the consequences of potentially doing intermittent therapy like that. But I think the infections are a real concern with these drugs. To address that, one of the pilot projects I've had going on at U of M is to use some wearable devices it's like a pilot study where we'll give patients a wearable temperature patch that it connects to their phone and can send temperature readings to a website that we can access to look at their temperatures every 1 to 2 minutes. This is useful for starting the bispecific drugs if we're looking for cytokine release syndrome, or monitoring for early infections, and just trying to see if that kind of approach is useful, particularly in research interest in reducing infection risk in older adults with myeloma. And that's trying to at least see if this sort of platform might be helpful in being another way we might, if we did detect a fever, how we might go about addressing that, if that's related to either the cytokine release syndrome early on, or if there might be signs of infection. But I think it's a really area. It's like along with the benefits that come from controlling myeloma better with these new drugs, they come with risks. And I think we have to, it's early in their use where I think we have to be really cautious with them and acknowledge that we're still gonna be learning a lot more about what's the best way to use these drugs.
Did you name about a specific drug in the beginning? I didn't catch any.
I did not.
Several.
The trade name for it is called Tecvayli. It's made by Janssen Pharmaceuticals. There are many drug companies that have versions of this that are in development. Pfizer has one, Regeneron has one, AbbVie has one. And then those are all against this BCMA target, which is the same protein that the CAR T cell drugs are made to go after. There's some other proteins that are being developed as targets using the same kind of treatment platform. So I think that these drugs are likely to revolutionize myeloma treatment. I think they're all very active. I think they come with real risks though. So I think we just need to be cautious as they're developed to make sure we get as much benefit with as little harm from these drugs as possible. Which drugs? Litutamab?
Yeah, with the.
Which is it?
Is that?
Isatuximab or?
Oh, yeah.
No, that's not one of those. That isatuximab is a CD38 monoclonal antibody. But no, there's that one's been approved on the market for a while now. Yeah. The only bispecific drug that's approved right now is Tecvayli for myeloma. There's some that are being developed for lymphomas. There's another one that's approved for lymphomas. And there's at least 5 to 7 of these drugs in development for myeloma that are going to be coming out, that are in various stages of development. So I think the Pfizer one's probably going to get approved at some point. Janssen has another one that's going to likely be approved. That's a different target than the Tecvayli. It's called talquetamab. So unsure when these would come to market, like when there would be approved, but I think people are suspecting that they probably would get approved sometime soon.
It really sounds to me like the most important thing in these new drugs is monitoring and the doctor taking care of the patient because of so many risks and so many new things.
I think you have to really be cautious about, trying to pick, both assess the patient and understand the type of treatment and the risks that come from the type of treatment to make sure that you're trying to help without causing harm, I think is the important feature. And, these new drugs that come, it's a two-edged sword. I mean, they require admission to start for the most part at this point. And I think that for many people, it's scary. I think we have to, treat these like new drugs with respect and think about trying to personalize as much as we can the patient approach based on the patient, their medical problems, so like what they bring to the table, in addition to what the drug risks are. So it's all got to be, I think, individually talked about, especially with what prior treatments other patients have had. Maybe there might be other drugs that could be used that might have less risk than the new ones. So it's all part of what we talk about in the clinic when making decisions about what's the next way to go if someone needs a new type of myeloma treatment.
It's not just like in what I would say the olden days, because I'm old, where you got penicillin and it just did something, you didn't have to worry about so many other things, but these are so much more.
There's a lot to balance. They're potent. Yeah. They're
Very different.
Yeah.
You're talking about drugs. It makes me wonder, all these companies are developing new drugs for specific disease. Is it because of an aging population, or is it because of environmentally it's causing myeloma? I mean, there's just so many drugs to choose from and more coming down the pipeline for one disease.
Yeah, I think that there's been a lot of progress in treating myeloma, and a lot of the method, like the classes of drugs that we have that have come about have worked for myeloma. Unfortunately, we don't have any that seem to be curative for myeloma yet at this point. So patients continue to need ongoing chronic therapy. And so even though we have an exciting new drug that works for a while, everyone seems to lose effect from that at some point in time. So there continues to be need for new drugs, and I think that it's wonderful that we have like a lot of these new drug technologies can be used to help myeloma patients. But you know, I think it's why are there so many drugs? I mean, I think we found things that have worked. I mean, I think that then there's been variations on drugs that we know work, and trying to use science to understand like what do we know about myeloma that could be a hook to go after. And I think that the you know, as a community, you know, industry and academia put a lot of effort into trying to understand myeloma and understand how to develop drugs against it. And it's, I think, been to people's benefit, showing how much myeloma care has changed over the last 20 years.
It's also, sounds like often enough, some of these drugs that were developed for myeloma work for other forms of cancer as well, or they're testing these drugs for other forms. Is that right? It kind of starts here and then.
Yeah, I think that the platform of these like bispecific antibodies, the whole idea of bringing the T cell close to the tumor cell is something
Yeah.
that's being interchanged to apply to other diseases. So instead of choosing BCMA, which is a myeloma surface protein, they swap out CD19 or CD20, which is a lymphoma surface protein. You could think about many other types of diseases where if you know the protein that's specific to that type of tumor cell, and you can make an antibody against it, which we've been able to do now for many years. You know, the antibody engineering technology is allowing this kind of approach to be developed, where you can swap out one piece of the drug and make it specific to a new disease and leverage the same kind of effect. Like if we know T cells kill those cells of interest, you can just in a modular way swap out what the target is in a way that I think is really, you know, interesting.
Pretty neat.
Yeah.
Are some of these newer treatments that like you're discussing, they always come later in your myeloma diagnosis? It's not, you know, like further down the line in your treatment?
It starts that way. I think that oftentimes clinical trials of newer drugs where they don't know the dose or the schedule, or they're understanding how to develop it early, they usually lately have been in people who've had at least 3 different types of myeloma treatments and have had progression on 3 different types of myeloma treatments or more. That varies by trial, so it's not a general rule. I mean, I think there's different trials for different populations. What happens is usually the drugs are initially studied in people who had not other great options for myeloma. And that's where I think the early development of these bispecific antibodies, at least, was for people who've had, you know, 4 or more prior types of myeloma treatment. It's an area of high need. And I think once it shows activity there, then there are other trials that happen where they try it earlier on and with people that have had less prior treatment. And we have a few different trials in progress from industry participants that have earlier use of these types of drugs. I think that the challenge is trying to balance the benefit of the risk of the new drugs with what we already have. So for the earlier trials, you know, for example, some of these phase 3 trials what a phase 3 trial is one of the, oftentimes the last trial is done before a drug's FDA approved. Well, they'll take a new drug or a new combination and compare it to a combination that already is on the market. And so that we have comparative data between a new combo and like what's already approved. And many times if that drug shows benefit over what's already approved, then that's enough for the FDA to say that this is a new combo or a new drug that we should have. So it marches from later lines of therapy earlier as we demonstrate the efficacy, how well it kills myeloma cells and how deep people's remissions get and how long those remissions last, as well as the safety, you know, side effects of the drug, infections, like other consequences, just to know how safe the drug is.
The longer you're on treatment, whether it's maintenance, assuming maintenance, do you become more and more immunocompromised over time and treatments,
I
or
think
an individual?
I think that depends both on the drug and on the individual. I think that for patients on maintenance, I don't think that there's progressive immune compromise. I mean, I think until the disease relapses and starts affecting the immune system more, I think people reach a stable level of immune compromise that stays over time. I think that one of the issues with these bispecific antibody drugs is they make your T cells work. And there's a concept called T cell exhaustion, where if your T cells are forced to work every week, all the time, forever, they get tired and they stop working as well. And so in that situation, you might think about if you're continuously pushing the T cell to do work, they could become tired and like help protect from infection later, and people could get potentially more immune compromised with that kind of approach later on. But it depends. It's a good question.
If you get an MRD negative test result, can you assume that your immune system is sort of getting back?
So the MRD test, so the question is, if an MRD test result is normal or negative, can you assume that your immune system is back to normal? I think that's hard to say. I think that the MRD negative test would show that they're in that wherever they sampled from, that there's likely no myeloma cells there. We think that has had value in detecting myeloma to very small degrees. It doesn't tell us much info about necessarily the rest of the immune system. There are some types of MRD tests that can tell us if there are normal plasma cells present.
I'll say your clonoSEQ test.
clonoSEQ would probably only tell us if the gene sequence of the myeloma clone is present or not. It wouldn't tell us about the underlying immune system much at all. But if someone is on, maintenance therapy or is on, sort of a less treatment and is MRD negative, I think that would be helpful to know, and at least subjectively would lead me to believe the person is probably less immune compromised. But I think it depends a lot on the therapy that the patient is currently on. But that's a good question. I mean, I think that clonoSEQ is this gene sequencing based MRD test, and there's some other types of MRD tests that are using flow cytometry as a method. And so what that does is it takes small amounts of cells from liquid bone marrow and runs them through a machine that can identify what types of cells are in that liquid bone marrow, and can give us back information about those cells in a way that's different than the clonoSEQ test. There are pros and cons to each of these approaches. I mean, I think that so far we think the primary use of the test is to understand, is there any trace amounts of myeloma that are left over at some point in time? But I think it needs to be taken in the context of, it's one sample from one place at one time point. So it's myeloma involvement can sometimes be patchy. So sometimes you'll have areas where maybe there's a small amount of plasma cells far from the bone marrow site that was biopsied. So I think that use of MRD, doing some kind of imaging with MRD is really important, because if you can, have like a PET scan, for example, someone could be MRD negative from the bone marrow, but then they may have a spot on the PET scan that could represent a myeloma piece focus of activity. And technically their MRD test is negative, but they could have some items. So I think MRD is exciting for detecting small amounts of myeloma cells, but it is a tool that has some shortcomings. I think as time moves on, I think how we best use MRD tests to potentially make clinical decisions, I think, is an important potential future development in the field. We've got a couple trials that we've been involved with that have looked at doing MRD testing along the road for myeloma therapy and then making decisions based on that. One of them is a large trial of maintenance therapy, where patients after their stem cell transplant get assigned either do Revlimid or daratumumab plus Revlimid or Revlimid alone. And then after 2 years can have an MRD test, which could identify their eligibility to either continue or stop maintenance. There's probably some patients in whom currently for maintenance, we give everybody indefinite therapy until it stops working.
Yeah.
There's probably some patients we're over-treating with that approach. It's difficult for us to know exactly who those patients are. We know for some other trials where they've used MRD to discontinue therapy, that patients with high-risk myeloma tend to have early relapses. So there's probably some in between, there's probably some myeloma patients that need ongoing therapy. And there's probably some other patients in whom we could potentially stop. MRD could be a way to assess that. I think it's still early days in that discussion and.
And
way to make
imaging
decisions.
isn't part of the standard of care per se, is it? I mean, for myself, I haven't had any since the very beginning.
At certain time points, I mean, I think that we'll oftentimes check imaging, around the time of diagnosis, oftentimes, after transplant, I'll check a set of imaging tests with the initial assessment after the transplant. But, regular imaging for myeloma is not necessarily standard practice. It depends. And I think that it depends also on the person. I think if one doesn't have a lot of monoclonal proteins that their myeloma makes, imaging can be more useful sometimes as a way to monitor the disease if you're less reliant on knowing the blood tests are going to tell you the story. In that kind of a situation, I might have that person get more regular scans because I think the M protein tests are going to tell us what's important. So it's individual. I think individual care is very
Very
important.
specific
Yeah.
and action. You said it, everybody's is different, everybody's responds differently on things, so. I don't, other people.
I want to tell everyone that's on the Zoom too, if you have a question, you can either type it in the chat or just unmute. David, you have a question?
I do. I'm sorry. Quiet. I'm sorry. Doctor, what is your experience with Revlimid and its causing neuropathy?
We're not hearing you very well. Here, hold on. Let me see if I can do this. I'm going to just do my microphone and see.
Now, how's that?
Maybe I hear a little, but I may the question. You had what my experience was with Revlimid.
Yeah, specifically with Revlimid, I do have neuropathy, and I'm struggling with it a bit. Some baseline due to Velcade years ago, and the question is, what is causing it now? And I'm doing some follow-up testing with neurology and others, which I understand is not your area, but specifically, I am on maintenance for Revlimid and wondering what is your experience very specifically with Revlimid causing neuropathy?
Great. So to repeat the question, and you said your name is David?
Yeah,
Hi, David.
it says Lauren.
I'm also Lauren. I'm very
Thank you for the question, David. So firstly, I'm sorry to hear about the neuropathy symptoms. Neuropathy is one of the most bothersome issues that we deal with that really affect quality of life in a negative way. So it's a big problem. So in general, certainly Velcade, I think, is probably the most notorious drug for causing neuropathy. And many times patients who get Velcade treatment can have neuropathy that can be a permanent problem related to nerve damage that comes from the Velcade treatments. It is also possible that Revlimid can lead to neuropathy. So Revlimid is a drug that was developed as a modified version of an older drug called thalidomide, which many of you may recognize or know. And this drug notoriously caused bad neuropathy. So one of the modifications in the development of Revlimid or lenalidomide was it seems to have less of a signal for neuropathy, but there is the possibility that lenalidomide and other drugs in that class can cause neuropathy. It just seems to be less so than the Velcade. Each person's case I treat as unique and different because I've had some patients who have no problems and get no neuropathy from these drugs. And I have other patients who clearly were doing, fine. They had Velcade years ago and we changed their treatments and, they end up starting Revlimid or pomalidomide or another drug in that class and then develop some symptoms of neuropathy that are new without having Velcade in between. So, no Velcade at the scene of the crime, I guess. And so you kind of have to then conclude that the other drug is probably contributing to that. So I think it's possible that Revlimid can contribute to neuropathy. I think that it's always good, to work with neurology to explore all the possibilities of what could be driving neuropathy, because there are many things that can also contribute beyond just the drugs for myeloma. So I think getting a comprehensive evaluation is always, I think, a good idea, and is something that I make sure I think about if people are getting worsening neuropathy in a situation where it's not the most common issue to happen. So I hope I answered your question. So I think, Revlimid can contribute. I've worked with neurology to explore, make sure other causes are excluded as well. Work with your doc to try to get some symptom relief if it's painful, particularly. The numb symptoms are kind of hard to treat. We can't really make it not numb very well, but there are some decent drugs that can at least try to help reduce the painful aspects of neuropathy if it's painful for an individual.
Here's a question here from Hal. Does Medicare cover the bite drug?
Yeah, so the bispecific antibody drug, teclistamab, so far it's because it was approved in late October and we've really only started, it's a very new drug. I don't think Medicare has had formal reimbursement guidelines for institutions who administer the drug yet. I think it's likely to be covered, but I think that it hasn't, to my knowledge, worked its way through the insurance and Medicare specifically, payments, reimbursement structures to have like a rule defined about it yet. But I expect that it would be. It's a good question. I think.
Well, Medicare.
Yeah, and even the insurance companies too.
Yeah.
So it takes time.
A little
But
different question. How is the U of M doing on their attempt to get another myeloma doctor after Dr. Yee left?
good question. We're trying hard. I think that recruitments for new docs can take some time, and there's a cycle of the year where I think, especially for someone like me coming out of training 5 years ago, like there's a regular schedule to that where people will be looking for a new position and, sort of January, February. So we don't have a new individual identified yet. We're working on it. I think it's a very active issue. We're trying to help
Your
solve.
workload went up a bit, I think.
It did. Things got a little bit busier in January, but both because of Dr. Yee's departure and because of some of these new drugs coming out. So I think Dr. Campanaro and I think have a great team so far. I think we just need to find our third musketeer to help us round out our workload and volume to help. Thank you. Hopefully we fix that soon.
Here's another question. This is from Tom R. I suffer from severe neuropathy and my pain doctor has suggested low dose of methadone. Any thoughts about that?
I think that's a good idea. I haven't had a lot of patients who've had severe enough neuropathy to consider methadone, but I do know that methadone in particular is less sedating as a long-acting opioid and does have some effects uniquely as an opioid for neuropathic pain. So I think it'd be a good thing to try if you run through some other options. But I think that's actually, it's a good suggestion. I haven't had really many patients at all end up on methadone because I think that we've ended up having, I think some maybe probably less severe neuropathy than you're having. I'm sorry you're having such trouble with that enough to need methadone. I hope that it helps, but I think it'd be a choice to try. The dosing can take some time, so just be patient with your doc and give them feedback on starting it and making adjustments until they find the right dose for you, because it may take some adjustments and time.
I think everybody here has had an issue with DEX. Are there some studies looking at possibly deleting DEX from the regimen, from some of the regimens?
I wish. I think that DEX is one of the more troublesome drugs we use. I'm sure that it's the issues are no stranger to many here, between the insomnia, the blood sugar issues, fluid retention, weight gain, the roid rage. It's like a big problem. So I think the hard part is with so many other studies and drugs in development, to do a DEX focused study can be challenging in this era. We got to some of the DEX doses we use now through studies in an older time when we didn't have a lot of other drugs available, so they would compare this old regimen of DEX, 40 milligrams daily for 4 days on, 4 days off was the old way that was done before we had any of these myeloma drugs. And then they compared it to 40 milligrams weekly, and the 40 milligrams weekly was like way less toxic. People live longer on the less DEX. Since that time, I mean, my practice is to liberally dose reduce and modify steroids to try to get patients to a place where they can get some benefit from the steroids and have some quality of life that's better than not being tortured by the DEX, I guess. It's sort of the goal, to find some middle ground, and it's hard. I think also each individual person, the idea of getting rid of the DEX after some period of time, if someone's had disease control for a period of time, talking with the risks and benefits of maybe trying to get rid of DEX as later on in a course of therapy to give someone a break from the side effects of DEX is an idea that I address with patients on an individual basis. There's no set time. 6 to 12 months of therapy, if the disease is looking like it's under control, could be a time to think about really weaning it off. But I think that what I understand is that still DEX unfortunately adds to what we do for myeloma therapy. So it is an active myeloma drug. It helps the other myeloma drugs work better. So there's no easy answer to that, unfortunately. I wish there was. But yeah, DEX is one of the more troublesome drugs we use. Yeah, Jim.
On that point, is there any of the drug companies doing anything to manufacture a drug that has got the same positive effects that dexamethasone has without the side effects?
Unfortunately not. I mean, dexamethasone, so it's a corticosteroid drug, which mimics some of the compounds our adrenal glands make. And there's a lot of effects of DEX. So DEX, I don't, in terms of exactly how DEX works, I don't know that we really have as deep an understanding of why DEX works or what DEX does. We know it's directly toxic to the lymphocytes and plasma cells, but there's a lot of effects that it has that, I think the short answer is no. Unfortunately, I'm not aware of any. But I think efforts to kind of limit the dose, if you can, in particular each person, is I think the route. I've heard of a version of DEX where they, instead of doing, it's like just like a larger, instead of like 4 milligram tablets, someone made like a 20 milligram tablet. That's kind of been the at least the amount of, that's the only new thing I've seen in that realm, unfortunately. But I think there's probably, it's hard. I mean, I think that there's probably not a lot. I think certainly patients would like to have less side effects from a drug like DEX that did the same thing. I think the hard part is that the steroids are so available and already integrated in everything else that we do, that to bring something in that would replace those would, I think, be a hard thing to try to develop.
Is prednisone the same as DEX or completely different?
Prednisone is a different drug in the same class as DEX. So
I've had prednisone for poison ivy, but dexamethasone was myeloma. I didn't know how different they were.
a little bit different. There's some different properties of various steroids that can have different effects. So our body makes lots of different subtypes of steroids, and so some of these have different activities that might more affect blood pressure or fluid retention. They're different. They're close, but not.
Myeloma, not
DEX is the one we tend to use more often than prednisone. There's some old regimens that use prednisone for myeloma, but largely DEX is what we've moved to, partly I think because the prednisone is a drug that's probably more suited to daily use. And I think that the weekly use of the steroids has been beneficial partly because if you use steroids daily, the adrenal glands get dependent on the daily steroids and stop doing their job and get weak. Whereas you do the DEX in a pulsatile way, it still lets the adrenal glands get a workout a few days a week and to still do what they need to do to not shut down.
Am I trained in the DEX as a long-term part of myeloma treatment?
It can be. I think it's an individualized piece of it as well. I try to, for my patients who are on what I consider to be a maintenance therapy, we try to get rid of DEX if we can, unless there's a specific reason why DEX might be useful. Yeah, yes, yeah, but we try to minimize it as much as we can. There have been some studies also looking at discontinuation of DEX. So there's one study that looked at Revlimid plus DEX for older adults who were not thought to be eligible for transplant. It used to be the old regimen was Revlimid and DEX continuously until time of progression. There was another study that compared, I think it was after 8 or 9 cycles, getting rid of the DEX and just continuing with the Revlimid. I think people were able to stay on treatment longer and not quit if they were able to get rid of the DEX. It's an Italian study that I think there's some benefits of having DEX on board for a little while, then if you can, try to get rid of it.
What, if any, medications you can offer to eliminate fluid?
So fluid retention is a challenging, problem. DEX can contribute to that. Steroids can contribute to it. Someone's kidney function can contribute to it. Their heart function can continue, and also just like the blood vessels that help bring the fluid from an affected area back to the heart. If those are affected, that can be a problem. So, stockings to compress the vessels to try to push the fluid in a certain way can be an approach that doesn't involve drugs. Diuretics that act on the kidney seem to be mostly the way to try to have the kidneys get rid of our excess fluid, since that's one of their primary roles is to try to have the kidneys pull the fluid out. I think that those are kind of largely the 2 ways to think about it, and then if there's anything that can be done to try to decrease fluid accumulation in the first place, trying to get off drugs that could cause fluid retention if you can, or trying to think about the diet. Sometimes salt intake can affect fluid retention as well, can be another factor.
So we're kind of over the hour time, and I know that Dr. Pianko has a busy schedule, and I don't want to take up too much of this time. So, I mean, so I think maybe we should stop it here. Is that okay? And then, if anybody has any other questions, you can always email them to me, and I can get some answers too from the doctors. But I don't want to take up all your time with this. But we thank you so much for.
My pleasure.
One part that we haven't asked you.
Well,
That's another half.
look, I think everyone's situation is quite different. So I think even with a problem that has the same name, everyone's situation can be vastly different. So I think that there's lots of reasons to be optimistic about the future for myeloma. I know that everyone goes through there are harder times and easier times. And, I think that really trying to keep a sense of optimism, I think, is important. And, that there are modifications. If you're having a hard time, that communicating those, can be useful to try to make changes to try to help things improve if one's having hard times. But I mean, I really see a bright future with a lot of new, very active drugs coming across the road for myeloma in a continuing way. Like, one of the things that excited me about myeloma as a field is that there has been so much progress, and it's been rewarding to be a part of ongoing new stuff coming down the road. And looking down the road, there's still at each phase of therapy, I think there's new exciting stuff that's coming. So it's I think hopefully going to be a continued pattern of new options for people to try to keep their diseases under control. And hopefully one of these options we get, one of these days can make the disease go away forever. I'd love to be out of work. But, we can hope for that. Yeah.
Well,
Thank you.
Thank you so
Thank you
much.
so much.
Really appreciate it.
Thanks to everyone online for joining. If you have any questions, please feel free to get in touch with Mickey, and I'm happy to answer any other questions that you guys have, okay?
Yeah.
Thanks for coming and spending time with me this morning, and look forward to our next event when
Yeah,
that may be, and
Well,
hope you enjoy this exciting series and.
Wine and the Deed is coming September 7th. And we do have some more of these doctor discussions too that are going on. So just check our website and you'll learn all about it. But we really, really appreciate your time. I think
My
it's
pleasure.
so informative and interesting. And you make it easier to understand, at least for the lay person.
Thank you so much, and
Yeah.
thank you. Well, thank you all so much. Hope you guys have a great day. Thank you.
Thank you. See everybody. See you online.